Welcome everybody to a new presentation, and in this presentation we are going to discuss an important role for the dentists in early detection of and diagnosis of an important disease which is osteoporosis. Osteoporosis, actually by the end of this presentation we would have an idea about the osteoporosis, what is osteoporosis as a disease, understand the possible causes of the disease and the risk factors, and identify, which is most important for the dentist, is to identify the risk or the radiographic signs of osteoporotic changes that are seen mainly on the panoramic radiographs, and we would identify the role of the dentist in guiding the patient or the next step, what to do if the dentist suspects the presence of osteoporosis in a given patient. Osteoporosis is a dangerous disease. It is dangerous because it is a silent disease. It doesn't show any signs and symptoms unless the bone becomes so fragile and it fractures. So actually, I would say that it is an important role for the dentist if he or she suspects that this patient suffers from osteoporosis, is to guide the patient and inform the patient of the disease, because it is a dangerous disease that would mostly pass unnoticed. Osteoporosis, by definition, is a skeletal disease which is characterized by low bone mass and low bone mineral density, which we will discuss. And there is a degradation of the microarchitectural nature of the bone tissue. Now, the low bone mass, the low bone mineral density, and this change in the architecture of the bone will lead to enhanced bone fragility and a consequent increase in the fracture rate or the fracture risk rate. According to the WHO, it shows that 33% of women above the age of 65 are affected by osteoporosis. As women age, after the age of 40, after the fourth decade of life, they lose about 50% of their cancellous bone and 30% of the cortical bone. The disease not only affects women, it affects also men, however, to a lesser grade. As men age after 50s, they would tend to lose 30% of the cancellous bone and around 20% of their cortical bone. Bone mineral density, or which is referred to as the BMD, by definition is the amount of bone minerals, specifically the calcium and phosphorus, which are present in bone tissue. Bone marrow density, in terms of the physical density or density in physics, is the amount or the mass of these minerals which are present in the volume of bone. So, in this diagram, which we see the difference between a normal bone, which has a normal content of minerals in the volume, in its volume, and another case of, or another, the diagram of presentation of an osteoporotic bone. You will see that in the normal bone they are thick, there is a lot of cancellous bone, and there is a lot of cortical bone. If you compare it to the osteoporotic bone, due to the shift or the change of or the decrease in the bone marrow density, you will see that there is a change in the appearance and the architecture of bone, plus there is a shift or a removal of the calcium and the phosphorus which is present in the bone, and hence the increased fragility of bone. These effects are mainly seen in the spine, in the vertebrae, vertebral spine, and in the femoral neck. And these are two places, common places for fracture in osteoporotic patients. There are so many causes of osteoporosis. We know that the maximum amount of minerals which are present in the bone is at in the age of 40s. Now, as we cross the age of 40s, when men and women, there is a change, there is a shift in the amount of bone marrow minerals, and after 40s, naturally there will be a decrease in the bone marrow which is present, or the bone marrow minerals. Now, this disease results of an increased bone breakdown by the osteoclasts and a decreased bone formation by osteoblasts. You know that in the process of bone remodeling, which occurs throughout life, there is a balance between bone formation and bone resorption. In osteoporotic patients, there will be an imbalance in these processes. There will be an increased activity of osteoclasts. Thus, it will resorb bone and remove the minerals out of bone to the blood stream. So this will result in the fragility and the reduction in the bone marrow density. Estrogen as a hormone, estrogen plays an important role in postmenopausal women. It aggravates or increases the effect of osteoclastic activity. In men as well, the estrogen levels, which are the decreased amounts of the estrogen levels which are present in men, will also or can play a role in causing the osteoporosis in men. The disease is seen with or may be caused by secondary hyperparathyroidism. The way of life or the activities of life or the nature of life, you don't see this, you would see this more often in active patients. Active patients actually can have, they will have a lesser chance of formation of osteoporosis. Decreased production of insulin like growth factors. Genetic factors play an important role in this, and there is the nutrition as well. Nutrition, decreased intake of calcium and vitamin D, and or the exposure to the sunlight will also help in developing osteoporosis. There are also risk factors which play a role in aggravating the disease. Hypogonadism, that is the diminished functional activity of the gonads, whether the testes in men or other ovaries in women, which may result in a diminished production of sex hormones, that is the androgen and the estrogen. Premature ovarian failure, low body mass index, people which have a low body mass index, ethnic or genetic factors, white women or white persons are more affected than black persons by the osteoporotic changes. Rheumatoid arthritis also help or increases or may induce the disease. Hyperkyphosis, that is the excessive curvature of the thoracic spine, which is commonly referred as the hunchback appearance. Smoking and alcohol abuse, and there is also the long term of the use of certain medications like glucocorticosteroids, anticoagulants, anticonvulsants, chemotherapeutic drugs, and the gonadotropin releasing hormone antagonists or agonists. So there are lots of these, risk factors and causative factors for the disease. Diagnosing osteoporosis is relatively easy, and there are so many methods which are used. There is the non-invasive methods, that is the ultrasound bone measurements, especially in the calcaneus of the calcaneus, that is the heel bone, and there is the bone densitometry, which is especially for the hip or spine. The WHO established a diagnostic criteria for the osteoporosis on the basis of the bone marrow density T-scores. The WHO considers that the measurement of the dual energy X-ray absorptiometry, which is the DEXA, or abbreviated as DEXA, this is the gold standard of diagnosing osteoporosis. The T-scores, which are recommended by the WHO, describes the patient's bone marrow density in terms of numbers of standard deviations by which it differs from the mean peak value in a young, healthy person of the same age. What does this mean? It means that the DEXA is done for a healthy person of the same sex, which is usually at the age between 25 to 40, which is the maximum bone formation. Now, the T-score is the number of standard deviation which are less than the normal or the T-score values for this healthy young man or woman to whom the DEXA was formed. By so, the threshold of 2.5 standard deviation below, that is minus 2.5, below the mean of a young adult woman, is the criterion of a diagnosis of osteoporosis. So, the man or woman performs DEXA, and by computer calculations, the DEXA number, the standard deviation, is compared against the normal DEXA or the T-score of a healthy patient. How much this number is less than the standard deviation, this will be considered as the if it is less, then it is the patient has, if it is minus 2.5, then the patient is described to have osteoporosis. The criterion of diagnosing of osteopenia, that is low bone mass, is more than 1.5, is more than 1, but less than 2.5. So less than 2.5, osteoporosis. Between 2.5 and 1, that is a minus from the normal one, this is osteopenia or reduced bone mass. The dual energy X-ray absorptiometry which is referred to as DEXA, or DEXA depends on the DXA and the DEXA are actually the same. This way of diagnosis, or this method of diagnosis, the osteoporosis, is, as we said, the gold standard in measuring the bone marrow density. This is done by using two X-ray beams with different energy levels. The X-rays are directed mainly at the femoral neck and the lumbar spine. Soft tissue absorption is subtracted from the resulting image, so the bone marrow can be determined from absorption of each beam by bone. How this is done, the two X-ray levels, it is performed by using two X-ray beams with different energies, very low energies, that is 40 and 70 kilo electron volt. Now the attenuation coefficients, which vary with the energy of the X-ray. The difference in total absorption between the two energy levels by bones can be used to subtract out the absorption of the soft tissue, leaving just the absorption of bone, which is considered as the bone density. So the patient, it's a simple process, very low X-ray energy used, that is 40 and 70, which is even less than a normal what we give for our periapical radiographs, and the beam are directed towards the hip and the femoral neck. Two X-ray levels, two X-ray energies are directed to these areas, and each of them will be, or each of these energies will be absorbed by soft tissue and the hard tissue. What the computer does is that it subtracts the soft tissue, leaving the absorption of the soft tissue, so it is leaving only the absorption of the hard tissues. Now the difference between the absorptions of those two levels by bone will be calculated by the computer as a standard deviation from the normal absorption. T-score values, the normal score is -1 and above. This is this is compared against, as we said, as a normal healthy patient, young patient between 25 to 40 of the same sex. The low bone density, which is considered as the osteopenia, is between -1 and -2.5. Osteoporosis, if the T-score level is -2.5 from the normal absorption of -2.5, of course, and more from the normal T value. These are two radiographs for a normal hip, femoral neck. This is, see, the level is -0.7. So it is more up to the normal, while here, see the amount of, this is a -4.6. This is an exaggerated case or a severe case of osteoporosis. See the great deal of thinning of the bone, reduced cortical bone, and reduced cancellous bone, which is present. Of course, a bone with such low mineral content can easily fracture, especially, which this is the femoral neck, which is the common site of fracture. Once the disease is diagnosed, there are drugs that can reduce the rate of bone resorption, which are called as generally anti-resorptive agents. Mainly these are as a treatment, which are used as a treatment, is the estrogen, calcitonin, as hormones, calcium, and the biphosphonates. However, there are so many articles that relate the development of osteomyelitis, chronic osteomyelitis, in patients using the biphosphonates, which is another topic to be discussed for the future. Now, if you or us as a dentist would suspect or diagnose the patient from our OPGs as a possibility of having osteoporosis, then the persons who we would refer the patient to is the rheumatologist or an endocrinologist or an orthopedic. Now, of course, we as a dentist, treatment of osteoporosis is beyond our scope of work, and however, we have the responsibility to advise the patient and let him or her know that they might be suffering of the disease, and we would refer the patients accordingly. Now let's come to our work. How would we decide, or how would we know that from the OPG that this patient might be a candidate of or might have osteoporosis? There are certain measurements that are done, which are collectively called as the morphometric indices, which are obtained from the OPGs. What are these morphometric indices? These are, first is the mandibular cortical index, which is abbreviated as the MCI. This is the appearance of the inferior cortex of the mandible, or the cortical erosion. Tell you the truth, this is the most or the easiest one to follow. It has no measurements, as that. It's just a way of observation of the cortical index, as we will see in the upcoming slides. The other one is the mandibular cortical width, which is the MCW. That is the measurement of the cortical width at the mental foramen region. So here we have a measurement, but here we will have appearance. There is no measurement in the mandibular cortical index. The third index is the mental index. The mental index, or MI, is the mean of the widths of the lower border of the cortex below the two mental foramina, measured on a line perpendicular to the bottom of the mandible at the middle of the mental foramen. Here the definition might appear a bit complicated, but as we will see the radiographs, we will understand how it looks, or what does it mean. The fourth is the panoramic mandibular index, the PMI. This is a ratio of the mandibular cortical thickness. Mandibular cortical thickness, so it's a ratio on the line perpendicular to the bottom of the mandible, that is the inferior border of the mandible, at the middle of the mental foramen. So far it is similar to this one, by the distance divided by the distance between the inferior mandibular cortex and the bottom of the mandible. I know that these are a bit confusing, but we will discuss them in the other slides. The antigonial index is the measurement of the cortical width in the region anterior to the gonion at the point identified by a tangent line along the anterior border of the ascending ramus, perpendicular to the lower border of the mandible. And here the normal value of the measurement is equal to or more than 3.2 millimeter. This is actually the thickness of the mandible at the antigonial region in simple terms. The gonial index is the mandibular cortex thickness measured on a bisector of the angle between the tangent lines posterior to the posterior border of the mandible, and this has a value of around 1.2, more or less equal to more than 1.2. The MM ratio is the ratio of the mandibular height to the distance from the center of the mental foramen to the inferior mandibular region, or the ratio of cortical width distance from the mental foramen to the inferior cortical margin. So far we have seven indices, which are collectively called the morphometric indices, which are used in diagnosis osteoporosis. Let's come to each of these. The mandibular cortical index, which is, as we said, the easiest to perform, is known as the mandibular cortical index. That is the appearance of the inferior cortex of the mandible. We are looking for the cortical erosion. Clemetti et al. Has developed a way of expressing the or description of the appearance of the inferior cortex of the mandible. The inferior cortical bone from the mental foramen, which is the reference point here, to the third molar is classified as C1, as you can see here, the endosteal margin, that is this one, this is a C1, the endosteal, that is the inner margin, the endosteal edge of the cortex is flat, solid, and sharp on both sides of the mandible. This is C1. C2 is a resorption cavities, which is characteristically defined as a half-moon defects. Half-moon defects, which are observed again on the endosteal, compare between this one and this one, on the endosteal edge of the cortex, or the endosteal cortical residues between these layers are observed. So instead of having a thick, solid, flat appearance of the inferior cortical index, here you will have either semilunar or half-moon defects, or you will have residues, areas of bone resorption. This is classified as a C2 index. C3 index, on the other hand, you will observe the area from the mental foramen back to the molar region. C3, you will see the cortex shows severe endosteal residues and is clearly porous. So this is actually as a subjective way. It's not an objective. There's no measurement here. What you have to do is that you will, after in a patient over 60, over 50, a female, you will let us make it a trend or train our eyes to see the inferior cortical border of the mandible, the endosteal side, from the mental foramen backwards. If it is thick, solid, and flat on both sides, okay, there is no presence of osteoporosis, at least from the OPG. If there is defects or residues, or this one is no resorption, is C1. If there is a simple residue or irregularity or a half circle appearance, then this is a C2. C3, on the other hand, you will see that the bone is completely irregular, the endosteal margin, as you can see in here, and there are lots of residues. This is a severe case, which is called, or which is as took by Clementi. It is a C3 case. If you see these three cases, or C2 or C3, please refer or ask your patient or guide your patient to see either a rheumatologist, endocrinologist, or an orthopedic specialist. Another case here, this is see, even the quality of bone differs. This is a C3. There is almost loss of the endosteal margin. Compare it to this one. See this line, this is the endosteum of bone. Compare it to this. You can hardly see it as a continuous line. Here it is less. There is a residue. So this is a C1, this is a C2, and this one is a C3. As I said, this is the most and the easiest way if you don't want to go into measurements. This is the easiest way of comparing or detecting the possible presence of osteoporosis. We would ask our patient to go for a DEXA examination to confirm the presence of osteoporosis. The second method is the mandibular cortical width. This, what we do is that there is a line parallel to the long axis of the mandible and tangential to the inferior border, this one. And there is another line which is, you draw two lines, one parallel and tangential to the lower border of the mandible on the OPG, and there is another line which is parallel to it. What you do then is that you drop a line perpendicular to those two lines, intersecting the inferior border of the mental foramen. So it passes actually in the center of the mental foramen, and then you are going to measure the cortical width at this area. So we are going to measure this area, because this is lower border of the mandible, this is the endosteal border of the mandible. We're going to drop a line perpendicular to these, and it passes into the center of the inferior border of the mental foramen. Now what we measure is this. The measurement, the mean value is 4 millimeters plus minus 1.2. This is for men. For women, it's 3.9. So if you find that this is less than 3 millimeters with the presence of a C2 or C3, then this is a possible case of osteoporosis. So this is the second method. The third method is the mental index. In the mental index, the mean of the width of the lower border, which is the mean of the width of the lower border cortex below the two mental foramina. Mandibular cortical thickness measured on the line perpendicular to the bottom of the mandible, inferior border, at the middle of the mental foramen, and the normal value is 3.1. So the mental index actually is the a mean of the two measurements of the mandibular index, which we measured in the previous radiograph. You're going to add them both and divide by 2, and you should have a mean more than 3.1 value. So it's 3.9 here, 4 point something. You add them together and then you divide. If it is more than 3.1 millimeter, this is considered as a normal value. The panoramic mandibular index is the ratio of the mandibular cortical thickness measured on a line perpendicular to the bottom of the mandible at the middle of the mental foramen by the distance between the inferior mandibular cortex and the bottom of the mandible, which is the mean corticular width is A, right? As we agreed from the previous measurement. Panoramic mandibular index is the ratio of the measurement of A divided by B. A, the mandibular cortical width, divided by the panoramic mandibular index, which is measured in the previous radiograph. This measurement should be equal or more than 0.3, because we are dividing the smaller measurement over the longer measurement. It is important that this line should be passing in the middle of the mental foramen, because in the mental foramen we want to have a certain reference point that we refer to. Except for the mandibular index, which depends on the appearance. All the other indices are actually a real measurement that are done on a panoramic radiograph. Now, if you are working with a digital radiograph, then each system has its own measurement or ruler. If you are working with the old type with the analog radiographs, with the analog OPG, then you are going to use a normal ruler. Of course, you have to consider the magnification, which is around 1.2. So whatever you measure in the radiograph, you divide by 1.2 if you are using the analog radiograph. If you are using a digital radiograph, which is more common now, then you would go for the calibration or the measurement of the system that you are using. The antigonial index is you would extend a line which is tangent to the anterior border of the ascending ramus. Okay. Now the line, it is going to intersect with the two parallel lines, one tangent to the lower border, the other one is tangent to the endosteal border. Okay. Now you're going to draw these lines. Then you are going to draw a tangent at the anterior border of the ramus down on the on this mandibular width, cortical width. It is important that you draw it here because this is the area of the antigonial notch. This is the gonial angle over here. This is the antigonial agent. So we have shifted our measurements from the mental foramen backwards to the antigonial notch. Now this measurement, normally if it is this thickness over here, if it is more than 3.2 millimeter, then the patient is in a safe condition. If it is less, then there is a chance of a osteoporosis. The gonial angle or the gonial index is the mandibular cortical thickness measured at the bisector of the angle between a tangent line to the posterior border of the mandible and the inferior border of the mandible. Now the area where the bisector, exactly here, you see this red circle, the measurement of the cortical thickness, the measurement of the, exactly here, the measure of the cortical width at the bisector of the posterior, a line that is tangent to the posterior border of the ramus, and the inferior border of the ramus. The bisector here is this is the gonial angle, 1, 2. This is the gonial angle. So you measure the thickness of the mandibular cortex at the gonial angle. And this is, if we would consider it normal, if it is equal or more than 1.2 millimeter. Now we are moving posteriorly. Okay? The last measurement, which seems to be the most complicated, actually it is not. What you do here is the mandibular height ratio. Here you are going to draw a line tangent again, we are back to the mental foramen. We are going to draw a line which is tangent to the alveolar bone, and then another line which is which passes at the center, exact center of the mental foramen, this one. So you will draw a line parallel to the alveolar bone, and then you're going to draw another line which is parallel to this one with the passing in the center of dental foramen. And another line which is parallel to these two will be passing or tangent to the alveolar border of the mandible. Next, you're going to drop a line which is perpendicular to the alveolar. Since these are three parallel lines, then the line which is perpendicular to the alveolar bone will be perpendicular to the line passing through the center of the mental foramen, and then there is a line would also be perpendicular on the line which is perpendicular on the the one which is parallel to the inferior border of the mandible. Now let's come to the measurements. What you are going to do is that you are going to measure the mandibular height expressed here in A divided by on the line from the measurement B, which is from the mental foramen down to the inferior border of the mandible. The normal values of the mandibular height M to the mandibular foramen ratio B is on the right side is 1.5 to 2.9, and on the left side is 1.3 to 3.1. So we'll do it on the on two bases. These might not be always similar, they might differ. So, to recap, osteoporosis is a dangerous disease. You would expect it to in menopausal women after in the mid-40s and 50s, and in men over after 55 to 60. It is a silent disease that might cause the fracture of bone, which is characterized by an imbalance of bone remodeling process, that is removal of calcium and increased fragility of bone. It is painless, it doesn't cause any symptoms, but as the disease progresses, it may lead to fracture of bone. The dentist can play a role in early detection of this disease by viewing the panoramic radiograph. There are certain morphometric indices, simple one, or you can go for the a little bit complicated. It's a matter of measurements, actually. You just draw a line and you follow the indices and follow the normal values as stated here. By the end of this presentation, I would like to thank you and excuse me, it's been a little bit long, and you can refer to these references, which are stated at the end of the presentation for further reading. Thank you very much, and hope to see you again in future presentations.